Presentation is on the surgical options for the management of chronic aspiration. There are more than a dozen different surgical procedures for the treatment of chronic aspiration. Which operation for which patient will depend very much on quantifying the severity of the aspiration. For mild symptoms, mild degrees of aspiration, a diet modification and perhaps some exercises would help these patients. It's rather common to have mild degree of aspiration, particularly in the elderly and in certain neurological conditions. Moderate aspiration would require some intervention in the form of swallowing rehabilitation, different exercises and different head and positions would also help, plus the dietary modifications. But it is the severe aspiration that requires tubal feeding or is life-threatening, that requires surgical intervention. And these surgical interventions can be straightforward, like in a peg feeding or a tracheostomy, or could be more complicated, like crico-pharyngeal myotomy, injection and medialization of the vocal cord, arytenoid medialization and rotation, laryngeal suspension, cricoid resection, laryngoplasty, and laryngo-tracheal separation, and finally either partial or total laryngectomy. And this is the other important factor in the choice of the surgery for aspiration, the precise identification of the defective factor in the swallowing, like for example a glottic incompetence, failure of hyolaryngeal elevation or anterior displacement during swallowing, tongue-based factors, loss of laryngeal sensation, crico-pharyngeal dysfunction, or any of these factors or any combination of these factors. This should be precisely identified prior to embarking on any surgical intervention. The other important aspect of the choice is we always try conservative rehabilitation first before surgery. But the length of the period of rehabilitation should be carefully weighted against the possible complications, the limits of the conservative rehabilitation to correct a defect. So that would need some consideration. We also need to consider whether the defect is reversible. In that case, you would think about temporary or reversible procedures, or whether the defect is permanent, and then you would think about more ultimate solutions for this. Should keep in mind that revision surgery for aspirations or alternative surgeries are rather common. It's common to have one or two or even three procedures to try to sort out the problem of aspiration. We can sometimes buy time with a peg, but if the problem is life-threatening and is deemed to be irreversible, then we think about the more radical type of surgery like resections, laryngeal shunts, and part or total laryngectomies. To assess the severity and the cause of the aspiration, most patients would have a video fluoroscopy. And if the penetration aspiration scale is also used, it would grade the severity of the aspiration depending on the depth of the aspiration down the airway. It's an 8-point scale with 1 and 2 passing as normal. There is no aspiration or minimal aspiration that is ejected above the level of the vocal cord, and 7 and 8 are the most severe, when there is aspiration below the level of the vocal folds into the trachea. And both 7 and 8, the aspirate materials is not ejected, sometimes with some effort to eject it, and in 8 there is no effort to eject it at all. That's silent aspiration. And in between 1 and 2 and 7 and 8, there are various degrees of aspiration depth, whether the aspirate materials contacts the vocal folds and is ejected or not, or whether it is below the vocal cords but it is completely ejected. The other essential diagnostic test for aspiration is the functional endoscopic evaluation of the swallowing, with endoscopic evaluation of the larynx and the hypopharynx during swallowing of colored bolus, and this would identify problems like glottic incompetence or impaired laryngeal sensation, reduction in the movement of the larynx towards the hyoid, for example, reduced duration of laryngeal closure in combination with delayed swallowing response or prolonged pharyngeal transit time. With the help of these two diagnostic tools, the video endoscopy and the video fluoroscopy, we would want to answer this important question: the timing of the aspiration in relation to swallowing, because this could point to the defective factor. If the aspiration occurs before the start of the swallowing, then it's usually due to poor handling of the bolus in the oral cavity, for example, or a delayed swallowing initiation. If the aspiration occurs during the swallowing, then it's usually either a glottic incompetence or laryngeal incompetence, failure of the protective mechanisms in the larynx. If the aspiration happens after the swallow, it's usually due to a residual bolus in the pharynx, due, for example, Crico-pharyngeal disorders, or due to sensory laryngeal deficits. One of the early considerations in the treatment of aspiration is whether a patient would be helped with a tracheostomy tube or not. Tracheostomy can help in securing the airway and providing a way of suction for the aspirate or the retained secretions in the lower airways. But tracheostomy is not a permanent solution for aspiration, and at best it can buy time until definitive surgery can be undertaken. Two-thirds of the patient with tracheostomy tubes aspirate because the tracheostomy tubes would actually reduce the glottic functions, the normal phasic glottic functions and the glottic closure, and also reduce glottic reflexes. Tracheostomy tubes would also fix the trachea in the lower part of the neck and would decrease the laryngeal elevation required during swallowing. The cuff with a tracheostomy tube is usually ineffective, and cuffed tubes would press on the upper part of the esophagus, increasing the difficulty with the swallowing and probably increasing aspiration as well. Another surgical procedure to be considered is cricopharyngeal myotomy for cricopharyngeal disorders identified by video fluoroscopy, like in this example, or video endoscopy. You could see here that the bolus is retained just above the upper esophageal sphincter, and this is the cause of the spillover into the laryngeal airway. For the cricopharyngeal operation to work, you would need to be sure of three factors. The contractility of the pharyngeal muscles should be intact, the sensation of the larynx and the hypopharynx should be normal, and the movement of the larynx and the hyoid upwards and anterior during swallowing is also preserved, because without this the cricopharyngeal sphincter would not open even after the myotomy. Cricopharyngeal myotomy would help patients who have mild or moderate degrees of aspiration. If the aspiration is severe, other procedures have to be combined with the cricopharyngeal myotomy, like medialisation procedures for vocal fold palsy, thyroplasties, or hyodoplasty if there is decreased elevation of the larynx during swallowing, or even partial laryngectomy to narrow the airway and provide better control of the aspiration. If cricopharyngeal dysfunction is diagnosed, it's usual to start the treatment with Botox injection before embarking on the definitive surgery. Endoscopically, A dose of 80 to 120 units of Botox can be injected into 3 points along the circumference of the cricopharyngeus muscle. If it works for maybe 4 to 6 months and can be repeated. And the important thing is that it is a trial of therapy. If it works, it provides evidence that the cricopharyngeus myotomy is also going to be helpful. Cricopharyngeus myotomy is one of the commonest operations for oropharyngeal dysphagia. It can be carried out endoscopically or by an external approach. If it is done endoscopically, sometimes it can be carried out with a flexible scope with some sedation, or more commonly, it can be carried out under general anesthesia with the use of a rigid scope like the Weirda scope. The blade of the anterior blade of the scope will be placed anterior to the cricopharyngeus bar, and the posterior blade will rest on the posterior pharyngeal wall, and a laser would be used to incise the cricopharyngeus bar down to the level of the buccopharyngeal fascia. That's the white color in here. It's important to get into this level so as to reduce the resting tone of the muscle by about 50%. The operation by dividing the muscle does not abolish the resting tone of the sphincter altogether, but it can be reduced by about 50% to help in the opening of the upper esophageal sphincter. The complication rates for the endoscopic approach is about 6%. It's mostly some bleeding or sometimes restenosis of the muscle, but serious complications could happen if there is a perforation of the buccopharyngeal fascia and mediastinitis may develop. If the operation is carried out by the external route, it's usually done on the left side of the neck, dissection between the larynx and the trachea on the one side and the carotid sheath on the other side down to the level of the prevertebral fascia, identification of the recurrent laryngeal nerve, and then rotation of the larynx and the pharynx medially would expose the posterior wall of the pharynx, and the myotomy would extend not only through the cricopharyngeus muscle but also through the lower part of the thyropharyngeus muscle and the upper part of the esophageal circular muscles. And this would ensure a better result for the cricopharyngeus myotomy. Another common cause for aspiration is glottic incompetence, either due to vocal fold palsy or persistent glottic gaps following injuries or operations. In glottic incompetence, the aspiration would usually happen during the swallowing and can be seen during video fluoroscopy and video endoscopy. The treatment for glottic incompetence would start with a trial of voice therapy to enhance a better glottic control and closure, and perhaps laryngeal elevation as well during swallowing. If this fails, then vocal fold medialization procedures, either by injections in the vocal folds or by type 1 thyroplasty. If the gap is posterior and it is large enough, perhaps with unequal levels of the vocal folds, then arytenoid rotation procedures may be considered. Crico-Thyroid plication, which stretches the vocal fold and adducts the vocal folds further, would also be helpful. If there is a persistent gap, despite all these attempts, then a reshaping or resculpting of the whole laryngeal structures by laryngoplasty may be considered, including cricoplasty, in which parts of the cricoid would be resected to narrow the airway and help in the control of aspiration. Cricopharyngeus myotomy can be added to any of these procedures to improve the aspiration control. Vocal fold medialization by injection was usually carried out under general anesthesia with a rigid scope, but can also be carried out under local anesthesia with direct visualization with a flexible laryngoscope. The needle will be passed through the cricothyroid membrane and directed upwards into the vocal fold level. injection will be carried out in 1 or 2 spots as far laterally as possible from the vocal fold edge, and this would help in closing the glottic gap anteriorly. The outcome of vocal fold injection with various materials in the improvement of voice is well established, but these are another set of objective tests used to measure the outcome of vocal fold injection for another indication in the management of aspiration rather than in the improvement of voice. And it did show significant objective improvement in the indices for various pulmonary, cough, and swallowing parameters, including things like improvement in the maximum expiratory pressure, maximum inspiratory pressure, peak cough flow, and also a significant drop in the penetration aspiration scale within 2 weeks and within 3 months, and a significant improvement in the oral intake scale, again within 2 weeks and within 3 months. The results did show that vocal fold injection in the management of aspiration works better for mid and anterior glottic gaps rather than in posterior glottic gaps. Another vocal fold medialization procedure is the type 1 thyroplasty with some added advantages. It's mostly done under local anesthesia, under direct vision with the use of a flexible nasolaryngoscopy. And this would allow the monitoring during the operation of the amount of the medialization, and by the changing of the position or the size of the prosthesis, the best glottic closure can be obtained. The operation entails making a window in the exposed thyroid ala, and through this window, the prosthesis would be applied to displace the vocal fold, and with some modification of this prosthesis, you can have a longer flange that can also displaces the arytenoid cartilage medially and helps in closure of the posterior glottic gap. The window is placed just below a line extending from the midpoint of the thyroid notch to the lower border of the thyroid cartilage. And this line is usually about 12 millimeters to 13 or 14 millimeters from the lower edge of the thyroid or from the thyroid notch. And along this line, you would leave the first 12 millimeters and make a window with a length of 12 millimeters and a breadth of 6 millimeters, a height of 6 millimeters. And this would leave enough strut inferiorly and anteriorly to avoid obliteration of the anterior commissure area, and inferiorly to avoid any fracture of the thyroid cartilage during the placement of the prosthesis. And various prostheses are being used to displace the vocal fold and checked in position and in size to affect the best possible glottic closure. The essential step in the procedure is the creation of the thyroid ala window with the right position and right dimensions. Through this window, the prosthesis can be applied to medialize the vocal fold and close a glottic gap. The prosthesis can be either pre-made or can be a titanium clip, like in this example, or it can be carved from a silastic block with certain dimensions. The base of the prosthesis should be about 12 millimeters with an added shoulder on both sides of 2 millimeters each and a height of about 6 to 7 millimeters. And once in position, it medializes the vocal fold and closes the glottic gap as seen in this coronal CT scan. The next step to consider if there is a large posterior glottic gap or unequal vocal fold levels or continuous aspiration after a failed thyroplasty is to consider surgical procedures to adduct the arytenoid cartilage. And this includes things like injection, augmentation of the arytenoid cartilage itself, or placement of a small implant into the crico-arytenoid joint, or fixing the crico-arytenoid joint by sutures in an adducted position, or pulling the lateral crico-arytenoid muscle, which is the main adductor of the arytenoid, forwards and laterally, either through thyroid ala or through the cricoid cartilage. These procedures, the arytenoid adductor procedures, can be complementary to thyroplasties, to crico-thyroid approximation, or cricoid plasty operations, or crico-pharyngeal myotomies. If there is a persistent posterior glottic gap after partial laryngectomies or after laryngeal injuries, one way of sorting this out is injection into one of the arytenoids that is going to augment the arytenoid and help in closing the posterior glottic gap. Another alternative to control a persistent posterior glottic gap after partial laryngectomies or after laryngeal injuries is to insert a small stainless steel nail through the crico-arytenoid joint into the cricoid plate, and this would displace the arytenoid cartilage medially and helps in the control of the posterior glottic gap. The operation is done under general anesthesia with microlaryngoscopy approach. Another medialization procedure for the arytenoids in posterior glottic gaps is the adduction arytenopexy, in which the crico-arytenoid joint is opened, a 4O proline on a cutting needle is passed through the posterior plate of the cricoid and retrieved through the medial part of the crico-arytenoid facet. And then the needle is passed through the body of the arytenoid and retrieved again to pass through the crico-arytenoid facet out from the posterior plate of the arytenoid again, and then a slip knot is done and tightened, and this would adduct and fix the arytenoid in the adducting position and help in the control of a posterior glottic gap. But the procedure that is used more commonly in the adduction of the arytenoid is the arytenoid rotation procedures, and this would entail rotating the arytenoid in the adducted position by mimicking the action of the major arytenoid adductor, the lateral crico-arytenoid muscle. A needle is passed in the muscular process of the arytenoid and pulled along the fibers of the lateral crico-arytenoid, either through the thyroid ala in the original description of Ishiki, or around the cricoid in the modified version of this. And this would mimic the action of the lateral crico-arytenoid and adduct the arytenoid and help in closing a posterior glottic gap. In the original description of the arytenoid rotation procedures to adduct the arytenoid described by Ishiki, the sutures around the lateral crico-arytenoid muscles were passed through the thyroid ala and fixed in this position. So it is an arytenoid thyroid plication procedure. In fact, the fibers of the lateral crico-arytenoid passes all the way to the cricoid cartilage, and Haji came up with the modification of pulling out the sutures around the muscular process of the arytenoid along the fibers of the lateral crico-arytenoid and securing it around the cricoid rather than the thyroid cartilage, and he suggests that this would give a more physiological adduction. The muscular process of the arytenoid cartilage can be approached through a window in the thyroid ala, much like the window created for the Thyroplasty operation, just inferior to a line and from the midpoint of the thyroid cartilage that extends parallel to the inferior border of the thyroid cartilage. It should spare the first centimeter or 12 millimeters anteriorly and you should spare also about 12 millimeters or more inferiorly, and have a window with about 12 to 14 millimeters in length and a height of 6 millimeters. The window should never extend beyond the oblique line of the thyroid cartilage, because then the window would open into the piriform fossa rather than into the larynx. If the operation of the arytenoid rotation is done on its own without being combined to thyroplasty, then a smaller window in the thyroid ala will be required. This smaller window would have its cranial or upper limit just superior to the mid-horizontal line of the thyroid cartilage. Its caudal or inferior limit would be about 8 millimeters from the inferior border of the thyroid cartilage. Its posterior limit should never cross beyond the oblique line of the thyroid, because then the piriform sinus mucosa would be exposed, and its ventral or anterior limit should be about 6 millimeters from the oblique line. Removing the cartilage and creating this window would expose the underlying muscles, and you could see that the thyroarytenoid transverse fibers or the lateral crico-arytenoid oblique fibers would be clear. And if you look at the point where these two directions of fibers merge, it would be the muscular process of the arytenoid. The depth of the dissection to reach the muscular process of the arytenoid is about 1 centimeter from the outer table of the thyroid ala, or 5 millimeters from the inner table of the thyroid ala. The thickness of the thyroid ala at this point is usually 5 millimeters, and an extra 5 millimeters would expose the muscular process of the arytenoid. It's important to note the position and relation of the recurrent laryngeal nerve in relation to the thyroid ala window and the dissection to the muscular process of the arytenoid. The recurrent laryngeal nerve passes just medial and deep to the crico-thyroid joint, and it's also just lateral to the posterior crico-arytenoid muscle, which again is inserted into the muscular process of the arytenoid, but more posteriorly. This is another approach to a control of a persistent glottic gap in cases of aspiration, the crico-thyroid plication. It mimics the action of the crico-thyroid muscle by approximating the anterior cricoid arch and the inferior thyroid horn with a sympathetic suture. The crico-thyroid muscle action would elevate the anterior arch of the cricoid closer to the thyroid cartilage, and also displaces the cricoid posterior plate backwards, thereby stretching the vocal fold and adding to its adduction. So it's a very short and simple procedure that can add to the adduction of the vocal fold and control a persistent glottic gap. We now move to another set of procedures designed to control pre-swallow aspiration rather than aspiration during the swallowing itself. And the pre-swallow aspiration, due to, for example, delayed initiation of the swallowing reflex or limited excursion of the hyolarynx upwards and anteriorly under the base of the tongue to protect the airway from the incoming bolus, the defect can be cured by lowering of the epiglottis further. What keeps the epiglottis in its normal position is a combination of ligaments and a fat pad anteriorly. By transversing the pharyngo-epiglottic ligament vertically and suturing it transversely, much like a Z-plasty, this would elongate the pharyngo-epiglottic ligament and allows lowering of the epiglottis towards the arytenoid cartilage. This can be helped by further dividing the glosso-epiglottic ligament, and this would allow further lowering of the epiglottis towards the arytenoid and protection of the airway from a pre-swallow aspiration. The lowest part of the posterior protective mechanism of the larynx is the inter-arytenoid area, through which some spillage of saliva or bolus can happen into the airway. To control for this, a transposition flap, mucosal flap, from the posterior cricoid area can be taken and rotated into the inter-arytenoid area to augment its vertical dimension, and this can be done with microlaryngoscopy under general anesthesia. Endolaryngeal stents with various designs can be used to plug the larynx and the upper trachea above the level of the tracheostomy tube to decrease or prevent aspiration. It can be useful to buy time before definitive surgery or in the very frail patient who is not fit for the definitive operation. Laryngeal suspension operation is another procedure that can be used in pre-swallow aspiration when there is usually a defect in the excursion of the larynx and the hyoid superiorly and anteriorly during a swallow to protect the laryngeal airway from the incoming bolus. In this operation, the larynx, the upper trachea, and the hyoid are exposed. The infrahyoid muscles are divided except of the thyrohyoid muscle, which would be left intact. The thyroid would be reattached to the hyoid by Gore-Tex sutures, permanent sutures, and then dissection above the hyoid to expose the lower border of the mandible, and drilling of holes lateral to the mental foramen. And then Gore-Tex sutures are also used again to suspend the whole of the hyoid laryngeal complex to the mandible and displace it anteriorly and superiorly. This operation of laryngeal suspension, or laryngohyoidopexy as it's sometimes called, is started with an insertion of a PEG tube for feeding in order to immobilize the surgical field in the early postoperative period. During the operation itself, it is important to connect the thyroid cartilage and the hyoid bone in such a way as to have the thyroid cartilage displaced a bit anterior to the hyoid bone. This arrangement would help in the posterior displacement of the epiglottis and lowering of the epiglottis over the laryngeal inter-aortus to protect it from the incoming bolus. The operation is also combined with a liberal Crico-pharyngeal myotomy, and this would help in further opening of the upper esophageal sphincter and reducing the risk of aspiration. The long-term results of this laryngeal suspension operation is quite good. Even after few years from the operation itself, more than half of the patient would have a complete success in that they can have oral feeding exclusively, and about 18% would have partial success with some improvement in the oral intake, but they would still require some modification of the diet. And about 30% of the patient, just less than a third of the patient, there is no much improvement in the swallowing or the aspiration. In some selected cases of post-swallow aspiration due to cricopharyngeal dysfunction and failure of complete opening of the upper esophageal sphincter, cricoid partial resection may be considered. In this procedure, the posterior plate of the cricoid cartilage is resected extramucosally. This will cause anteroposterior narrowing of the airway and widening of the hypopharyngeal exit, and this would help in the clearance of the bolus and also reduce the chances of aspiration. If the previously discussed procedures fail to restore glottic or laryngeal competency to prevent aspiration through the larynx, the next step would be another set of procedures designed to separate the endolaryngeal airway from the endotracheal airway to prevent the passage of the aspirate material from the incompetent larynx down to the lower airway. One of the commonest procedures in this group is the Lindeman Laryngo-tracheal separation procedure, which has several modifications. Basically, in this procedure, the trachea would be exposed and divided between the second and the third ring. And then the lower part of the trachea would be brought through the skin to form a tracheostomy, and the upper part of the trachea would be closed up with sutures, and the suture line would be reinforced with a muscle flap to prevent leakage into the wound. The operation can be modified by implanting the upper part of the trachea into the hypopharynx and the esophagus so that any aspiration or any mucus collecting into the larynx or the trachea will be drained through the pharynx and the esophagus. The Lindeman laryngo-tracheal separation procedure was meant to be a reversible operation so that if the swallowing improves with time, the operation can be reversed by re-anastomosis of the proximal and the distal ends of the trachea and restoration of endolaryngeal, endotracheal airway, and phonation. However, it was noticed that the re-anastomosis of the distal and the proximal ends of the trachea is frequently complicated with subsequent narrowing, difficulty in endolaryngeal or endotracheal respiration, and also a high incidence of complications, including wound breakdown, fistulas, or restenosis. One simple modification to the Lindeman laryngotracheal separation procedure is the double barrel tracheostomy. The problem with the Lindeman procedure is that by forming a closed pouch out of the proximal part of the trachea, accumulation of the aspirate material and the mucus can cause infection and can cause a leakage, fistulas in the neck. This double barrel tracheostomy modification, the upper tracheal segment will be brought out through the skin over the sternomastoid muscles and sutured to the skin so that any aspirate material or mucus into the trachea or the larynx would be drained to the outside to prevent the infections and the wound breakdown. Another set of operations that can be used to obliterate the airway completely in cases of intractable life-threatening aspiration while still retaining the larynx is the laryngoplasty operations. The supraglottis can be closed either by a vertical line of sutures, like in the Biller's supraglottic laryngoplasty, or it can be closed horizontally like in other modifications. In the Biller's supraglottic laryngoplasty, the edges of the epiglottic fold and the epiglottis will be freshened, part of the epiglottis will be trimmed, and the supraglottis will be closed by a vertical suture line that can be enforced by fascia or muscles to prevent leakage or wound breakdown. Alternatively, supraglottic closure can be achieved by a horizontal suture line through an open lateral pharyngotomy approach. The edges of the aryepiglottic folds and of the epiglottis are freshened, and the supraglottis is closed in a horizontal suture line, perhaps helped with release of the epiglottis by dividing the glossoepiglottic ligament through a lateral pharyngotomy approach. Alternatively, the supraglottic horizontal closure can be achieved with an epiglottic flap by the transoral endoscopic approach rather than an open approach. The epiglottis will be lowered by dividing the glossoepiglottic ligament and bilateral pharyngoepiglottic ligaments division. Then the edges of the lowered epiglottis will be freshened together with the edges of the aryepiglottic folds, and the supraglottic will be closed by a horizontal closure. This would prevent aspiration, but also there will be no phonation, and the patient would depend on a permanent tracheostomy. The operation have the potential of being reversed if the condition of the swallowing improves, with the restoration of endolaryngeal breathing and phonation. In some cases, closure of the endolaryngeal airway by laryngoplasty is required at the level of the subglottis rather than the supraglottis, like for example in the Biller's laryngoplasty. In this case, the cricoid cartilage together with the central part of the thyroid cartilage will be resected. The laryngeal remnants will be closed up at the subglottic level to effect complete closure of the endolaryngeal airway. The patient will be dependent on a permanent tracheostomy. This would have the added advantage of widening of the hypopharyngeal exit area into the upper esophageal segment. And finally, when everything else fails to control intractable and life-threatening aspiration, one may consider either partial or total laryngectomy. Central compartment laryngectomy is one form of partial laryngectomies for aspiration with a resection of the cricoid cartilage, most of the arytenoid cartilages, and the major part of the thyroid cartilage. The laryngeal remnants are then sutured together, and the trachea is exteriorized into a permanent tracheostomy. This operation will have the added advantage of improving swallowing by decreasing the resistance of the upper esophageal sphincter. By this, we come to the end on this presentation on the surgical management of chronic intractable aspiration. Assalamu alaikum.